CEWT Talk is a weekly 20-minute podcast brought to you by the Continuing Education Workforce Training Division of Idaho State University's College of Technology. This podcast is part of our continuing outreach efforts, and the format is conversation. We're having conversations with businesses, professionals, entrepreneurs, community agencies, and in all cases, difference makers. You can find us on Apple Podcasts, Spotify, and SoundCloud. So subscribe today. Take 20 minutes and hear from people living in your community who are making a difference in your community. It's time to get started with CEWT Talk. Hello, everyone. This is Jason Batalden with the Continued Education Workforce Training at ISU at the College of Technology. And Paul, welcome. Good to see you on the show today.
I'm glad to be back as always. It's going to be a good show. We have a guest today who's in a field that I know nothing about, and I'm really excited to learn more.
No, I know so little about her conversation today that I literally got on the internet last night and just tried to learn just the terminology. So that just tells you how out of the loop we are today. But that's not a concern because we have an expert on the show today, and she has hosted several of our podcasts. And Raylyn, we're so glad to see you today. And really, we're glad to see you today because we're counting on your expertise and knowledge to kind of carry the show today. So Raylyn, welcome to the show, and I'm glad to see you. And how are you doing?
I'm doing great.
Good.
It's a good day.
Good. So you've got an exciting event coming up you want to share with people.
We do. We are so excited to be able to have the Emergency Medicine Conference hosted at ISU. PMC, Portneuf Medical Center, is our corporate sponsor for this event, our title sponsor, and we are excited to be able to do this with them again. Conference is scheduled for April 30th and May 1st. Registration opens March 15th. This will be located here in Pocatello on the ISU campus, and the cost is only $20, very nominal cost. We have brought in Eric Bauer. He's the CEO of Flybridge as our keynote speaker, and we're super excited to have him, as well as all of the other presenters that we've lined up. You're in for a treat at this Emergency Medicine Conference.
Well, that's exciting because last year thanks to, it was a little bit, about the same time last year, but they had to cancel the conference due to the COVID and the pandemic issues. So we are extremely excited to be bringing back this year. So good job. Way to bring that back.
We're grateful that we're on this side of it, and it's exciting.
Very nice.
Excellent.
Well, Raylyn, you want to introduce our guest today?
I'd love to. So we have really the expert. I'm not the expert on interventional radiology, but we do have Dr. Jared Bailey. He is the director of interventional radiology at Portneuf Medical Center, and he's a partner in Medical Imaging Associates. And so we are grateful to have him here to share his expertise and knowledge in the world of interventional radiology.
Well, thanks for having me, Jason, Paul, and Raylyn. I'm glad to be here. Interventional radiology is a great field. I'll just introduce myself real briefly, if that's okay.
Absolutely.
That would be great.
I'm actually not native to this area. I was born in Switzerland and grew up there for at least a few years, and then spent the majority of my teenage and kind of where I have always called home was in St. Louis, Missouri. I did my initial education here out west at BYU, Brigham Young University, and then did most of my medical training again back east in the Midwest. I was at Ohio State, Indiana University, and then did my kind of capstone fellowship training at the University of Michigan. And I knew I needed to come back west. I was really missed the mountains, missed all of the outdoor activities that I had become used to growing up. I grew up in a big family with 9 siblings, and so I brought my wife and 5 kids here out to Pocatello, and we've been here now for 6 years, and I don't see us leaving. We've really loved it here in southeastern Idaho.
Well, that's awesome. We're grateful that you're here.
Yeah, the West has that kind of hook, doesn't it? Once you kind of get it in your blood, it's hard to get it out.
Well, I'm from back east. When I moved here initially, I just went, wow, there's a lot of space.
But wonderful place, wonderful people.
Right.
And we didn't have any family in this area. We have family in some in Utah, but it was really the job and the opportunity to build an interventional radiology service here at Portage Medical Center that brought me here.
Well, Dr. Bailey, I'm coming into this cold. So what is interventional radiology? I did not go online like Jason last night and look it up.
It's a very broad field that is extremely technology driven, that has led to lots of minimally invasive approaches to treating things that patients are used to having to have really major surgery for, that are often now treatable as an outpatient setting with little more than a needle puncture to get their treatments. And so it's basically the simplest way to kind of think of it is it's really an image technology rich guided procedure or surgery that allows us to do minimally invasive things that again required bigger stuff. And I know our focus today is a little bit about on stroke side of things, and that's kind of almost the forefront of where interventional radiology has taken us, is the ability to do something like remove a clot from somebody's brain that is the cause of stroke and so much mortality and morbidity in our country today.
So when you say imaging, so are we talking about surgery with a camera then? Is that what we're talking about?
No. So a lot of our procedures are catheter divided, and I would divide our kind of specialty into 2 parts. There's the vascular and the non-vascular part. People who have a new tumor that is discovered, unfortunately, need a biopsy of that, and that used to all be done open. That's all done with needles, and we use ultrasound, CT, or rarely MRI to guide a needle into the tumor and get a sample. And, on the vascular side of things, not a camera, but really radiation or ultrasound is what we use to guide catheters, wires, needles, balloons, stents, or in the case of stroke, a big catheter to suck out the clot. And no cameras. It's all basically ultrasound and CT that we use to guide things.
So kind of like radar.
Yeah, kind of. Yeah. I mean, you can see directly what you're doing, when we use devices that are sensitive to ultrasound or radiation. But oftentimes we just see indirectly, not like you would with laparoscopic surgery where you actually put a camera in there.
Did you have a question, Jason?
Well, no, first of all, I guess I have a personal story, and I don't want to take it all away from Dr. Bailey, but my father had a stroke this past summer, and I get now, when they say they removed the clot, now I know how they did. So it sounds like to me, as scientific as it is, and I'm sure, and it is precise. I mean, my dad's 80 years old, and if he wanted to, could probably do a cartwheel. That's how he recovered. But it sounds like it's by feel almost. There must be more of an art to it than maybe even a science. It sounds as detailed and as small as it is.
Yeah, I mean, there definitely is an art to it with the kind of catheter and wire manipulations that we do, in a setting of stroke where somebody has an LVO is what we call it, where we get involved. Stroke is a big problem, and LVOs make up a small percentage of strokes, but nevertheless a very detrimental category of people with strokes, where they have a clot, we can actually see it on CT imaging, and their brain is still alive behind that clot. And so when people meet that category, that's where we get involved as interventionalists. And we often make our puncture as a small needle in the femoral artery, which is in the groin. And then from there, we thread our way all the way up through the aorta and the carotid artery, and then out to the brain, and get a hold of that clot and suck it out. Yeah.
That's how the doctor described it. Yep.
Yeah.
That's what happened with my dad. So.
Yeah, if you've seen any videos of it, it's incredible, to see that blood flow open back up in the brain, and that brain be able to really live again. So it's pretty cool. So my question is what, like when you went into medical school, did you know that this is what you were going to do, or did that just kind of come as you went? What caused you to choose this specialty?
Yeah, it was an evolving decision. My dad is a neurosurgeon, and so I thought that's what I wanted to do, and I really enjoyed my time doing that. But I found a really dramatic love for anatomy, which drew me to radiology first, which is a very image-based, anatomy-rich specialty where we're, constantly looking at the anatomy of the body and finding things, that are trying to figure out what's wrong. And in that process, I discovered interventional, which gave me kind of the more procedural side of things that I had kind of grown up hearing around with my dad, to be able to not only make diagnoses, but actually offer treatments and cures for people. And so it was a great hybrid solution for me to be able to, stick with the anatomy and using that as the driver of the way that we treat people, because that's really what the imaging is using the anatomy to find ways to, and imaging to find ways to treat people.
That's pretty awesome. Very cool.
Yeah.
Go ahead.
Yeah, well, you said that this is almost like an out procedure. I would imagine because of you're only going in with the small needle, that it's very unintrusive. Years ago, I'm an older guy. It was surgery, and you had to cut and go in. And now with this, it's just a guided needle that you go in. And does that also, because of the lack of intrusive surgery, does that reduce the recovery time as well?
Yeah, that's really the goal, and I will throw out a resource for people that are interested that go beyond what we can discuss in the podcast. There's an initiative called the Interventional Initiative. And so the website there is theinterventionalinitiative.org, where you can find little short 10, 15-minute vignettes about patients who've undergone interventional procedures and the kind of treatments they're offered, because it's so broad, it's so hard to kind of in a short time frame compress. But one example is interventional tries really hard to be at the forefront. One of the common problems that people deal with, particularly in the male population, is lower urinary tract symptoms from an enlarged prostate. Super common. Really, for a long time, the only option was to have a TURP, which is a pretty invasive procedure that people don't love some of the side effects associated with it. And nowadays, interventional has an option for patients with enlarged prostates and lower urinary tract symptoms, where we guide a catheter all the way out to the prostate and basically deliver small beads to shut off the blood flow to the prostate. And it causes the prostate to shrink. And in the majority of people, they can improve their LUTs. So it's an example of where yes, that's done. You come in the hospital, you have a needle puncture, you have this procedure done, you leave, 2, 3, or at most 6 hours later and go home. And there's still recovery, for sure. There is still recovery, but hospitalization time is dramatically less with interventional procedures over open options.
That's awesome. I mean, as somebody who's taken care of a lot of TURP patients, wow, that's amazing that you could be able to do that so quickly and without a lot of the problems that come with a TURP. So,
this is a technology. This is heavy on technology from what you're talking. So is this, and I guess I want to use the term relative. Is this a relatively new specialty in this area in radiology, or has this technology been around much longer than I'm assuming it has been?
Yeah, no, it's considered new. I mean, as far as formal training goes, it's only existed in the last 20 years, 25
Oh, right
years.
on. Yeah.
Prior to that, there were definitely people practicing interventional. The father of interventional, his name is Charles Daughter, and he was kind of up in the northwest coast in the Washington area, Seattle, and he is the one kind of founded the concept of using minimal invasive techniques to treat problems. And the first real procedure was an angioplasty of an artery, where he basically passed a smaller device and slowly increased the size to spread out the artery where it was narrow. And that was kind of the revolution was born. And that was in the 1960s.
Wow.
But technology has grown so fast. I mean, the stroke large vessel occlusion technology has really only existed in the last 10 years and is really only hitting the mainstream, meaning outside the big ivory tower academic centers, in the last 5 years. So it's really the forefront of medicine and what can be done.
And with
I'm sorry, I was just going to ask you. I mean, this is it seems like a fast evolving technology. Is there certain times that you're reading, say, trade manuals or working in the industry, and this new breakthrough comes in, and I go, oh my word, this is a game changer, and you go and you're anxious to try it out because, oh my God, it's right there. I can just use this on a patient, and I can see how it can help my patients.
Yeah, for sure. And what you described is exactly what happens regularly. And so, somebody who chooses this specialty really chooses to a lifelong of continued medical education, because what I'm doing, I was told this when I joined, that what I'd be doing 20 years into practice would probably be very different than what I was doing as I trained. Not as completely different, but as an evolution where the ability to do things that we didn't think were possible become possible. And so it is. We commit a lot of time to maintaining on top of the literature, on top of kind of the data and evidence for the procedures that we offer, and to find better outcomes. That's really the end goal, is better outcomes with lower risk to patients. So yeah, heavily driven technology.
I mean, do you look back at like 5 years ago and go, oh my word, we were using horse and buggies back then?
Yeah, I'd say 5 years is probably a fair analogy. I mean, it's amazing. It's like the frog in the pot, right? I mean, It's hard to see the change from day to day, but when you look back, yes, there's things we're doing today that 5 years ago I thought, that was maybe going to be done at very select centers across the country and are now widespread available.
I would imagine it's a little bit like cell phones, right? You know what I mean? They change kind of gradually, but then when you look back, you're like, oh my goodness, look at where we were just 5 years ago and where we are today, and all of the different things that we can do. So you mentioned strokes. Great treatment for strokes that we didn't have just a few years ago, and for prostate. What other kind of common procedures would you do for interventional radiology?
Sure. I mean, the vascular heavy procedures, we tend to rely heavily on hospital resources because they're very resource intensive as far as the equipment. But far more common is just venous insufficiency. So we've all heard of varicose veins in the legs, and kind of painful tender legs, which is primarily a disease of the female, but definitely happens in males, is a procedure or is a disease process where interventional is heavily involved. So patients with varicose veins and venous insufficiency have great treatment options that are for sure outpatient elective cases. So that really is kind of probably makes up a third of our practice, is taking care of venous insufficiency patients in the clinic. Other areas where we kind of provide the whole package is we take care of patients with peripheral arterial disease. So the venous insufficiency is a vein problem of the legs, and the arterial insufficiency is an artery problem. So people who tend to have atherosclerosis, we all have heard about coronary artery disease and heart attacks. Well, the same process happens everywhere else in the body, and in the legs, it can limit people's ability to walk and be able to ambulate and do the things they want to do. And that can all be treated from an interventional perspective.
Nope.
Go ahead.
Go ahead.
No.
I was just going to ask you where that, where I guess the crossover from the interventional radiology into your cardiologists, where they're doing the treatments for atherosclerosis and that type of thing.
Yeah. There definitely is crossover across different practices here. Here in Pocatello specifically, our cardiologists are just completely focused on the heart. If it's outside the heart, it falls into our realm. We share, crossover with vascular surgery for sure as well. But if it's outside the heart here in our community, the treatments and the workup and all that are provided from the interventional side of things. And yeah.
So Jason gave us a story about his father earlier, but I would imagine that you run, strokes are typically, not always, but typically older patients who aren't aware of technical, advances. Do you ever have those patients that are just, almost approach your procedures as modern day miracles?
Yeah, it's focusing on stroke here again. We had a patient recently, unfortunately with COVID, one of the unknown side effects for a lot of the population regarding COVID is we've had an increased number of strokes, and we know there's a thrombotic effect from COVID itself, or if you have if you have COVID, the disease, caused by SARS. And so we've had younger patients with LVOs, again, the large vessel occlusions in the brain in the last 12 months, and it's happening all over the country. And we had a patient on the table who was completely paralyzed on one side, wasn't able to move the left arm or left leg, had a big clot on the right side of the brain in the M1 segment. And when we pulled it out, he started moving around on the table. And at first we were like, stop moving, put your arm and leg down. Don't move. And then suddenly we realized that, wait a minute, that's actually exactly what we want. When we pulled the clot out, he, immediately began moving his left arm and left leg again. And he, in a miraculous way, was discharged from the hospital within 2 days, which would have been a debilitating, complete paralysis on the side of his body. This is a 58-year-old male. So for sure, miraculous, for sure.
Well, Paul, I want you to know I'm not as old as some of maybe the patients you're referring to, and I think it's miraculous. My dad was in the hospital by 10:30, and by 11:45, they had came out and explained they had moved a rice kernel-sized clot from his brain, and he's down in Arizona golfing today. So, you know what I mean? I'll tell you what, for me, that was a miracle. So that was pretty cool.
Well, I would imagine that it's a pretty rewarding field, being able to see, people who normally would be paralyzed for the rest of their life, or have inability to talk, or being able to recover in that way.
Mm-hmm.
Yeah, I would agree. It's very rewarding field, particularly because the downtime from most of our procedures is so little, and how minimally invasive it is. And there are areas in our field where oftentimes we're the last option or the last resort. One of the areas that interventional gets involved in is acute hemorrhage. So it's common for patients who have a traumatic event to come in. We discover that they're actively bleeding somewhere, which previously required a huge surgery, and often now is just treated with the same technology as we use for removing clots, shutting down a blood vessel that's bleeding. And so those are really rewarding cases.
That's so cool. That's awesome.
So you mentioned earlier that your dad's a neurosurgeon, and that was a field that you were thinking about going in, but you went into this field. I would imagine the conversation between you and your father must be extremely interesting when you get together, because as a neurosurgeon, he again must deal with lots of advances in technology, and has many success stories that he can talk about. And I just wondered, how does that go between the two of you when you're together? Is it like a competition during Thanksgiving?
For a long time, and even in the medical community, interventional radiology is a specialty that remains a little bit unknown and recognized for what it can do. And the same was true with my dad. He had no idea what I was going into. And for a long time, he told me I made the wrong decision. And he had an opportunity to come out and help at Port Enough Medical Center to fill some locums coverage as a neurosurgeon. And so we got to work together at the same hospital for about a 2-year period.
Wow.
And so we were kind of in a close environment. I was able to show him, cases and stuff that we were doing. And during that time, he came around the corner and he said, "You know what? You made the right choice."
Oh, right on. Right on.
Excellent.
Well,
excellent.
I think it's kind of standard for all fathers to make sure their children know they are making the wrong decision, though. So we can't hold that against him, Jared. We won't do that.
No. We like to tease each other about it pretty regularly, but we get along well.
Right on. Well, I don't know. Did you guys hear the timer, Paul?
Yes, I did.
So fast.
I know.
It does.
So, Dr. Bailey, thank you so much for being on the show today. And I went from not knowing anything to even appreciating it more and more. So thank you for the information. And Raylyn, let's be sure we get the plug out. Emergency Medicine Conference, April 30th and May 1st. Registration opens March 15th. And if you're not already getting the emails, please contact us at cetrain.isu.edu. And that's cetrain.isu.edu, or you can call us at 208-282-3372. Dr. Bailey, thank you for being on the show today. Raylyn, thank you for carrying the weight for me and Paul today. Thank you very much.
Thank you.
Thank you. Thank you for inviting us on.